second year resident. Uh, I would like to thank the members of Durg Bhilai Academy of Pediatrics for lending me this opportunity to present a seminar. With your permission, sir, I would like to start my presentation.
Please go ahead, Dr. Niranjan.
Yes.
Yeah.
Riyan Setia, who is a 9 years old male child, born of non-consanguineous marriage, third by birth order, Hindu by religion, who was a student of 4th standard, being a resident of Bastar, Chhattisgarh, was admitted to Balgopal Children's Hospital on 4th of July. Informant was mother, who is reliable for the history. Child presented with complaints of fever since 6 days, vomiting and decreased oral intake since 5 days, yellowish discoloration of skin and eyes since 4 days, passing dark yellow colored urine since 4 days, and pain in abdomen since 3 days.
1 minute, 1 minute. Fever, just a minute. Okay, go ahead.
In history of presenting illness, child was apparently all right 6 days prior to admission when he developed fever, which was sudden in onset, high grade, intermittent in nature, with no diurnal variation. Fever was temporarily relieved on oral antibiotic. It was not associated with chills or rigor or rash, and it recurred daily. During the course of febrile illness, parents noticed that child had decreased activity and generalized weakness. After 1 day of fever, child developed repeated episodes of vomiting, which was preceded by nausea, occurred mainly after taking feeds, and vomitus contained recently digested food particles. It was non-bilious, non-projectile, non-blood stain, and it was associated with pain in abdomen. 4 days prior to admission, parents also noticed yellowish discoloration of eyes, which gradually progressed to involve the skin, not associated with itching. Later, child started passing dark colored urine, while stool remained normally pigmented, which was yellow in color. 3 days prior to admission, child complained of pain in abdomen. Initially, it was dull aching around the periumbilical region. It was later localized to the right hypochondrium, gradually increasing in intensity and worsened with movements. There was no radiation of pain, nor it was associated with any disturbance of sleep. Parents noticed abdominal distension with no palpable mass. Prior to 2 days of admission in Balgopal Children's Hospital, child was treated at a local setup where he received ofloxacin.
Go ahead.
Yes. Parents did not give any history of altered sensorium or excessive drowsiness or seizures or decreased urine output or clay colored stools or generalized pruritus or hematemesis or melena. There were no bleeding manifestations or rash. There was no exposure of child to flood water or rodents. There was no calf muscle pain or congenital suffocation. There was no chills or rigors or periodic fever pattern. Child didn't receive blood transfusion prior to admission, nor there was any history of injections at tattooing. He had no joint pain, oral ulcers, or photosensitivity. He had normal bowel and bladder habits. Child behavior was normal. There was no tremors or decline in school performance, and there was no history of hepatotoxic drug ingestion, herbal or indigenous medication use, or mushroom or toxin ingestion. In past history, child was admitted on third day of life in view of neonatal hyperbilirubinemia, with total bilirubin being 27 milligram per deciliter, of which direct bilirubin was 2.3 milligram per deciliter. For 4 days at an NSU in Jagdalpur, where he had received phototherapy as conveyed by parents. After discharge, child had no further admission child had no further history of readmission. Child had no history of surgery or chronic illness. In birth history, antenatal history.
Please go ahead.
Yes,
Go
sir.
ahead.
Mother had regular antenatal checkups, where she had 4 ANC visits. Pregnancy was booked and supervised. She had no history of pregnancy-induced hypertension or gestational diabetes mellitus or antepartum hemorrhage or fever with rash or urinary tract infection or torch infection or a history of jaundice during pregnancy or substance abuse or drug intake, except anabolic acid and calcium supplementation. She received 2 doses of tetanus toxoid. In natal history, it was a full-term normal vaginal delivery conducted in a government hospital at Urban Primary Health Center in Balangir with birth weight of 3.1 kg. He cried immediately after
There is
birth
some
and
background. 1 minute. Somebody. Hello? There is some background noise. Somebody is talking. Dr. Naresh, please mute them. Yeah. Please go ahead.
yes, sir. In natal history, it was a full-term normal vaginal delivery conducted in a government hospital at Urban Primary Health Center, Balangir, with a birth weight of 3.1 kg. He cried immediately after birth and required no further need of resuscitation. Mother blood group was B positive and child's blood group was A positive. In postnatal history, he was shifted with mother after delivery, and breastfeeding was initiated within first hour of life. He had passed urine and meconium within first 24 hours. At 72 hours of life, parents noticed yellowish discoloration of eyes and skin, for which he was admitted in view of neonatal hyperbilirubinemia in NICU for 4 days, and phototherapy was given. There was no exchange transfusion required, and baby was discharged on day 7 of life in stable condition. Breastfeeding was exclusively done for 6 months, and complementary feeding was started at 7th month with dal pani, khichdi, and cerelac. Breastfeeding was continued till 1 year and 8 months of age. In
Please go
developmental
ahead.
history, yes, sir. In developmental history, all milestones were attained at an appropriate age. At 4 years of age, parents noticed that child had difficulty in responding to distant calls, but was able to hear perfectly fine when they spoke directly from a close distance, which was approximately around 25 to 30 centimeters. Child had undergone brainstem evoked response audiometry test, which was suggestive of moderate hearing loss. Parents also noticed at 4 years of age that child had slurring of speech, which was initially normal. He was able to understand and follow the commands, but had slurred speech. In immunization history, child was immunized as per national immunization schedule till 5 years of age, and hepatitis B vaccination was given at birth. In nutritional history, child has mixed diet consisting of fruits, vegetables, cereals, dairy products, pulses, millets, meat, and poultry. He has habit of eating frequently from outsides, typically from vendors and hawkers. Uh, his total calorie intake per day was 1315 kilocalories per day, with a deficit of 375 kilocalories per day, and deficit percentage was 22%. And protein intake was 28.5 gram with a deficit of 1 gram per day, and deficit percentage was 3.38%. In family history, there was no history of similar complaints
Please go ahead.
in family history. There was no similar complaints in the family. There was no history of any liver disease, hemolytic anemia, Wilson's disease, or autoimmune disease. And it was a non-consanguineous marriage. In socioeconomic and environmental history, it is a joint family consisting of 12 members. Father is carpenter by occupation and mother is housewife, with two elder siblings consisting of 11 years old and 14 years old sisters who are school students. Per capita family income is 4,500 rupees. According to modified Kupuswamy socioeconomic scale, they belong to lower middle income group, to class 3. They reside in a kacha house consisting of 5 rooms, having 3 doors and 6 windows. Water supply is from borewell. They have 2 separate toilets and 2 dogs as pets.
Excellent. Excellent
Yes.
history. Dr. Naresh, I'm going to change the system of discussion. No, go. No need for summary. Just leave it. Dr. Naresh, you and Dr. Vijay start the discussion, then I will come in for a change. Dr. Naresh and Dr. Vijay, you both of you start discussing the history, then I will come in.
What are the main
Sir,
problems in this child? Dr. Niranjan, what are the main two problems in this child?
Uh, Sir, a child is actually from the history, it is seen that child has poor hygiene and poor sanitary practices, though they had separate toilets, and they were history of eating frequently from outside. So, following that, child had symptoms of fever, vomiting. Later, child had jaundice and pain in abdomen. So, typically,
Uh,
child oral intake was decreased initially, followed by
don't
jaundice.
elaborate now.
Yes,
Please be brief now. Your
yes,
history was quite exhaustive and wonderful, but now we have to shortlist the main things.
yes,
So it was probably what?
yes.
What was the probable problem now?
Uh, so I think child from the history which I have presented, I could shortlist that child might be having, since there was a history of fever, so it could be viral etiology.
It could be viral hepatitis.
Yes, sir. Or since child had abdominal distension, so it could also point out towards any hemolytic disorders.
Was the distension significant?
No, sir. It was mild distension. There was mild fullness in
Was it
flanks.
associated with splenomegaly?
There was mild splenomegaly. Yes, sir.
Liver?
Yes, sir. It was tender hepatomegaly.
So, if it would have been hemolytic jaundice, what is the age of this child?
Sir, age is 9 years old. He's 9 years old.
So, would it not have been presented earlier?
Yes, sir.
Will hemolytic jaundice be silent for so long?
No, sir.
And what is the second problem in this child? What is the
Sir,
second major problem that you have found in this child?
sir, child appears to have pain in abdomen, so it and vomiting. So it could narrow down to involvement of gastrointestinal system.
What about hearing? You told.
Yes, sir. So actually, parents noticed that initially child was hearing fine, but later at 4 years of age, they observed that he has problem from distant hearing. So from since child belong to rural background, so I think there might be a history of hearing loss, but parents realize it at 4 years of age.
Would it be related to what you found in the history?
Yes, since child had NSU stay history of 4 days, he was admitted for neonatal hyperbilirubinemia. So it could be caused. So it could be one of the cause for hearing loss.
Okay. I will
Yes.
request Dr. Balasubramanian and Naresh to continue.
Yeah, certainly. Naresh, your questions, then I'll comment. Naresh, are you there?
Naresh is probably sick today.
No
He
problem.
may
No
have.
problem. Okay. Okay. Now you go back to the first slide, Dr. Niranjan.
Yes.
First slide. Go back to the first slide in the history.
Shall I go to chief complaints?
Please go back to the first slide. First slide. Yeah. First slide. Yeah.
Yes.
This is the second slide. Second slide. The history of presenting illness.
Okay. Yes.
Yeah. Next slide. Yeah. Actually, you are given 5 important symptoms. But always when you start the history of present illness, you go to the next slide. Go to the previous slide. Don't move
Yes.
fast. Previous slide. History of presenting illness. No, previous slide. Yeah. You have said child was apparently all right 6 days prior to admission. What is the age of this child?
He's 9 years old, male child.
9 years old. Always PGs must have a habit of documenting apparent well-being in a child with an opening statement on the well-being of the child. For example, if it is a 9-year-old child, we expect the child to attend school, right? You
Yes.
expect even some children at 9 years will even be cycling to the school, something like that. Was the child indicating that the child was not ill at all before the onset of the illness? So you have said apparently all right. You could have added an adjective saying school going 9-year-old boy.
Yes.
Okay.
Yes.
Right? Develop fever. Okay, that is one. Second
Yes.
thing is, next to fever, he had developed vomiting. Next to vomiting, he had developed abdomen. Now I am going to ask all the PGs. You can put in the chat box. There are 2 children in front of you. one child develops vomiting followed by abdominal pain. Another child develops abdominal pain followed by vomiting. What is the difference between the two? I hope you get my question, Niranjan and others.
Yes.
One child, first vomiting and then abdominal pain. Another child, abdominal pain and then vomiting. What is the difference in your interpretation regarding the etiology of the abdominal pain? Anybody can put in the chat box also. Yes, Niranjan, what's the answer? Anybody can put in the chat box? Okay, if nobody is putting the answer, yeah, let me see if anybody is putting the answer. No. Okay. If nobody is putting the answer, I'm going to give you a clue.
Yes.
Very important general pediatrician's clue. Any child who first develops abdominal pain and vomiting, surgical cause is more likely. On the other hand, first vomiting, then abdominal pain, medical cause is more likely. This is just a rule of thumb. Because this doesn't have, whatever I'm saying, does not have 100% specificity and sensitivity.
Yes.
But by and large, if the pain starts first and then the child starts vomiting, it is likely to be a surgical problem.
Surgical course, yes.
And then a child who first gets vomiting and followed by abdominal pain, which is likely to be due to a medical problem. So here, which one started first? Vomiting.
Vomiting,
Okay.
yes.
So it's likely to be a medical problem.
Medical
that is
cause.
number one.
Yes.
Okay. Second, you put yellowish discoloration eyes and then the yellow colored urine, etc. What does that indicate?
Yes, sir. Sir, there could be hepatic involvement, child had jaundice.
What do you mean by hepatic involvement? It is likely to be a cholestatic jaundice
Cholestatic
or a
jaundice, yes, sir.
hepatocellular jaundice. Hepatocellular
Yes.
or cholestatic jaundice.
Hepatocellular jaundice, yes.
Okay.
Yes.
Okay. Then a child with hepatocellular jaundice or cholestatic jaundice, if there is pain in the right hypochondrium, what will you think of?
Sir, in hepatitis, as there is inflammation of liver, the Gleason's capsule there is stretching of Gleason's capsule which could cause the pain.
How common is pain a prominent symptom in acute hepatitis? Is it common or uncommon?
It's uncommon, sir.
Common or uncommon?
Uncommon, so it's not
Very,
that.
very uncommon.
Yes.
Most children with acute viral hepatitis or acute hepatitis, abdominal pain is not a great
Yes.
symptom. Great symptom. So you'll have to. So what will you think of if abdominal pain is associated with jaundice fever, right hypochondrial pain, other than hepatitis? I'm saying hepatitis is uncommon.
Sir, it could be either due to hemolytic anemia, or it could be
Why should
hemolysis.
hemolytic anemia produce right hypochondrial pain? How will it produce? Anybody can put in the chat box. The child who has jaundice has right hypochondrial pain, severe, and you think it may not be hepatitis. So what do you think of? Other
So it could be
PGs,
so it could be drug induced as well.
it could indicate the possibility of calculus or acalculus cholecystitis or cholangitis.
Yes.
That is the answer I expected from you. Abdominal pain per se in acute hepatitis is very, very uncommon. Excellent. I'm happy that Ojesh is putting in the chat box possibility of liver abscess also. Only thing is liver abscess, I mean, just only 3 days fever, pain abdomen, okay, and jaundice appearing before pain abdomen, that's very unusual. Jaundice as such in liver abscess is extremely unusual, but I'm happy that you thought of it. Good. Good. Okay. That is it. Okay. Next is, okay, he received ofloxacin. Go to the next slide. Go to the next slide. Next slide, Niranjan.
Yes, sir. It's just to.
Don't become nervous. Yeah. Then
Also,
you
I
have
have to
gone
show.
straight away. see, two things. Always, when you present the history, don't come to negative history so soon. You must elaborate on whatever symptom that happened earlier. Please go to the previous slide. In other words, please go to the previous slide. Yeah, you should tell what happened to the fever, what happened to the pain, what happened to the jaundice over the last few days. After all, the whole thing started, whether any of them is disappearing, any of them is increasing, any of them is regressing, before you talk about the negative history. Okay? And what
Yes.
happened? The fever regressed or continues?
Sir, fever regressed gradually over the hospitals with hospital stay.
Okay.
Yes,
Then
sir.
what happened to the pain abdomen?
So pain abdomen also it subsequently reduced, sir.
What about the vomiting?
The child had vomiting for a couple of days after admission. Then after that he was fine,
Stop.
and
Stop.
his appetite
What happened to
also.
the jaundice?
Yes, sir.
Yeah. What happened to the jaundice?
Sir, it was persistent, sir.
Increasing, decreasing, same.
It was decreasing, sir, on the decreasing trend.
It was that you could have mentioned.
Yes.
Again, what happened to the pain abdomen?
So pain abdomen. So it was mild pain actually, and after 2 to 3 days, child was all right, sir. He didn't complain of any pain in abdomen.
What
On the
happened to
day,
the urine color? What happened to the stool color?
so stool
It's
color was
important to mention the stool color.
yes, sir. So stool color was normal since the day of admission. It was yellowish in color, and urine color it was light yellow. It was not urine color was light yellow.
Was the stool pale or yellow?
It was yellow, sir. Yellow in color.
Okay, that you could. Then urine color, did it improve or did it worsen?
It improved, sir. Over a period of time, it improved.
You could have
Yes.
mentioned. What happened to the appetite of the child?
Sir, appetite gradually improved, sir.
Improved. Did it worsen after the onset of fever and illness?
No, sir, it improved, sir.
It improved. Okay.
With
Now go to the
subsistence of
negative.
fever, it improved, sir.
Okay, negative. Then you go to the next slide.
Yes.
Go to the next slide. Yeah. Why did you ask about altered sensorium, drowsiness, seizures, and all?
Sir, for ruling out hepatic encephalopathy,
Okay.
as it could progress to
Okay.
acute liver failure. Yes, sir.
Okay. Right. Did you ask about pruritus?
Yes, sir. I had mentioned in histopresenting illness that there was no itching. There was no such complaint of itching.
Okay.
Yes, sir.
Okay. Next slide. Why do you take so much time to change to the next slide? Yeah. Okay. You
So
went
there might
into
be some
the.
network issues.
Okay. What does this history tell you? Just focus on this slide. What does this tell you?
So on day third of admissions, baby developed yellowish discoloration, so it was pointing towards neonatal hyperbilirubinemia. So there could be various causes, sir. Like they could be it could have been ABO incompatibility or RH incompatibility, or it could have been G6PD deficient.
It is unconjugated hyperbilirubinemia
Yes,
or
sir.
it is
It is unconjugated.
Is it cholestatic jaundice or non-cholestatic?
Unconjugated hyperbilirubinemia, sir.
Yeah, do you accept a direct bilirubin of 2.3 as
No,
unconjugated?
no, sir, no, sir.
This is cholestatic jaundice. Yeah.
Yes.
This is not unless the report is wrong.
Yes.
Anything above 1.5 is
Yes, sir.
cholestatic jaundice of pregnancy. So that is why when you had put hyperpnea, I just saw that figure. This is
Actually, it was
cholestatic jaundice.
1.3, sir. It was a typing mistake. It was
You had
1.3.
put as 2.3.
Yes,
Oh
yes,
God. You had put as 2.3.
yes,
Okay. Then I agree. So if it is 1.3, it is not
yes, sir.
cholestatic.
Yes, sir.
Agreed. What is the urine color in the newborn period?
Sir,
You didn't ask.
I didn't ask.
So ask the urine color. You should ask for the urine color and stool color. So now you correct it. 1.3 means it is non-cholestatic, unconjugated. Go to the next slide. Go to the next slide. Go to the next slide.
Yes,
Okay. Birth weight is 3.5, good. And phototherapy was given for 4 days. Stable
yes.
condition. Did they do hearing assessment or thyroid assessment during the newborn period?
Sir, I inquired about that, but parents were not sure. Parents were not sure about it. They just gave me the
Parents
history
are
of.
not.
Yes, sir. They belong to rural background, so they just vaguely told me that baby had yellowish discoloration, so he was kept under blue light. And when I asked for whether they did any further assessment like Behra or autoacoustic emission, so they were not clear about it. They had no clue.
Okay. The urine was not yellow, the stools were not pale. Am I right? Okay.
Yes.
Postnatal history. Go to the next slide. Go to the next slide. Why are you taking so much time to go to the next slide?
So there is some kind of network issue, I guess.
No,
I have already
don't be
switched.
nervous. Yeah, be relaxed.
Yes.
No, don't be nervous. Be relaxed.
Yes.
Developmental milestones were attained at an. But can you say developmental milestones are normal when the parents have found that the hearing is abnormal?
Yes. Mm. Sir, actually, from history, it seems that there might have been hearing loss initially also, but they recognized it, they realized it at age of 4 years. Else, gross motor, fine motor
Okay.
was absolutely fine, sir.
What about the development of speech in this child?
So, according to parents, child had normal vocalization before until at age of 4 years when they noticed that he had difficulty in hearing from distance, and gradually following that his speech was also impaired, sir. So they realized
How,
it.
how, how many words did the child speak at 1 year of age?
So 2 to 3 words.
2 to 3 words. At 2 years of age, what do you expect a normal 2-year-old child to have as a speech milestone? Anybody can put in the chat box. What does a normal child do with regard to speech at 2 years?
Say 8 to 10 words you can speak.
8 to 10 words. Anything else? When does a child start putting 3-word sentences together? That is the answer. No political symbol.
2 years of age, yes.
2 years of age,
Yes.
and by 3 years, child should have a vocabulary of 100 words. Was it there in this child?
Yes, sir.
You should verify carefully by asking simple questions on speech with regard to the number of words, sentences, clarity, etc.
Yes.
You have not gone into detail. Please check once more. Check once more. Make it a habit to get a detailed history. I'm sure the speech development in this child also would have been definitely delayed.
Yes.
And in the development, what is the age of this child now?
He's 9 years old, sir.
9 years. In the developmental history in a 9-year-old child is incomplete without, I'm fond of repeating, 4 Bs. One is bowel, second B is bladder, third B is B. When I say B, it is sleep. Fourth B is behavior. These 4 B's should always be mentioned. And in a 9-year-old child, the school performance of the child also will give you a clue to the intelligence of this child.
Yes.
Handwriting should be inquired into. Handedness should be mentioned. Make it a habit. I'm repeating it. Often forgotten by PGs in the developmental history, please include bowel, bladder, behavior, bed means sleep, right? And in an older child above 5 years, ask about the school performance, which will give you indirect clues to intelligence and also about handwriting, and also a question regarding presence of dyslexia, where a child puts 6 as 9, B as D, etc.
Yes.
All these things are important. Did you ask those things?
No, sir. No, sir.
You should, right?
Yes.
And of course, clustering of speech you have mentioned at 4 years, and school performance. Even if the mother doesn't tell you, at least you can ask the mother what the school teacher felt about the performance of this child. Bowel and
Yes.
bladder control you should have mentioned, right?
Sir.
Next,
Yes.
go ahead.
Yes, sir.
Yeah. National immunization schedule. In fact, Dr. Vijay has put in the chat box hepatitis A vaccine. Because in the ones you have put, it is national immunization schedule. Obviously, it does not include hepatitis A vaccine. Go ahead. Next slide. Next slide. Yeah, your dietary history is very comprehensive. I mean, I'm very, very surprised. Please go to the next one. Next one. I'm surprised that the child is getting such a good amount of protein. You know, at least in South India, it doesn't happen. Child is getting a reasonably good diet. Calorie deficit also not very great. Child is
Yes.
getting about 1,300 calories. Not very bad, I would say, but though it is insufficient. Okay, right. Go ahead. Next. Of course, Dr. Vijay has already put, and I also asked, mentioned about the appetite of the child at the onset of illness and later. You said appetite is impaired and it improved gradually. Am I right?
Yes, sir. Yes, sir.
Okay, right. And of course, non-consanguineous marriage, no family history of any disease. Okay. Particularly, in addition to history of liver disease, hemolytic anemia, Wilson's disease, any any cholecystectomy history is also important. But
Yes.
why cholecystectomy history important? Why is that important? Anybody can put in the chat box. History of cholecystectomy. What does that give you a clue to in the presence of jaundice?
Sir, could
Anybody
be due
can
to
put.
obstructive jaundice to rule out. There could be history of obstructive jaundice.
Yeah, Dr. Likita has put correctly in the chat box, hereditary spherocytosis.
Okay.
Many an adult would have undergone cholecystectomy for calculate because of hereditary spherocytosis, an autosomal dominant disorder. Okay, right. Family history, nothing is happening because you should have added cholecystectomy in the family history. Next.
Yes.
Next slide. Yeah. Socioeconomic, fairly good enough. Next one. Next slide. Okay. Now, what is a summary of your history? What is the most probable diagnosis at this point of time from the history? Dr. Niranjan.
Sir, it seems like it would be a case of either infectious hepatitis, as child has a history of eating frequently from outside, or it could be as child was pale on admission, so it could be there could be history of hemolysis as well, or since child had mild abdominal distension, so I am even suspecting sickle cell anemia or thalassemia disorders. But predominantly, I am suspecting, sir, hepatitis of infectious etiology, from what it seems.
So what made you think of thalassemia or sickle cell anemia in a 9-year-old child who was presented with an acute febrile illness with jaundice? How do you explain? How many thalassemics or sickle cell disease will present like this without a single transfusion before at 9 years of age like this? Since you said, I am asking you.
Yes.
Absolutely unlikely. Absolutely unlikely. Okay? The only disorder you will have to think of in such a presentation is probably
Hepatitis.
hepatitis. Okay?
Yes.
Right. Dr. Vijay also puts it in the chat box. Sir, you can talk, sir. You can unmute yourself. You can add anytime, anything you want. Very, very unlikely. You will not see, I have not seen at least thalassemia or sickle cell presenting at 9 years, first time with fever and jaundice. That doesn't happen. Spherocytosis, yes, can fool you with the cholecystitis coming on. Even that jaundice might have been noticed earlier than that. So this is an acute febrile illness with conjugated or unconjugated hyperbilirubinemia. Do you think this history suggests that there is an unconjugated jaundice or a conjugated jaundice?
Unconjugated.
Unconjugated. Do you get unconjugated hyperbilirubinemia with the urine color being yellow?
Yes. Yes.
Huh? Hello?
Yes, sir.
No. It is conjugated. Yeah.
Conjugated, yes, sir. Conjugated.
Urine color being yellow, this is likely to be a hepatocellular or a cholestatic jaundice.
Yes.
So your conclusion is that 9-year-old child who has had neonatal hyperbilirubinemia with some hearing problem, with slurred speech, with motor development being essentially normal. Of course, you didn't mention about scholastic performance in the school, with no significant family history, presented with an acute febrile illness, with conjugated hyperbilirubinemia and abdominal pain, and you said abdominal distension on the right side from the history. Okay, so what is your most probable diagnosis?
So I would narrow it down to hepatitis, from what it seems.
Simple. This is a hepatocellular jaundice.
Jaundice, yes, sir.
With febrile illness, acute febrile illness. The most common, what is the most common cause? Is an acute hepatitis. And amongst hepatitis, do you think this is bacterial or viral?
So I think it's viral, sir.
Viral.
Yes.
Which virus is likely?
Sir, or it's hepatitis A virus is most likely. So A.
Most likely. Other than hepatitis A, what other possibilities are there with regard to acute hepatitis?
So it could be due to hepatitis E as well, or hepatitis B.
Hepatitis E. Okay, A, E. What else can it be?
It could be hepatitis B, sir, and other causes can also include, sir, in Epstein-Barr virus or cytomegalovirus or herpes simplex virus or
See,
dengue.
the important points that you must remember, coming to viral hepatitis, there are two groups of viral hepatitis.
Yes, sir.
One is viral hepatitis caused by
Hepatotropic viruses. Yes.
The other group is caused by non-hepatotropic viruses.
Viruses. Yes.
Amongst the hepatotropic viruses, hepatitis A and E are the most common ones.
Yes.
Right? Followed by hepatitis B, C, etc. Delta. Okay.
Yes.
And non-hepatotropic, all your CMV, EBV, herpes simplex, adeno, many viruses can cause hepatitis, including influenza.
Yes.
Including dengue. Though it doesn't cause icteric hepatitis, it can cause hepatitis. Okay. This looks like an acute hepatotropic virus causing acute. What are the bacterial infections which cause acute hepatitis?
So it could be enteric fever, sir.
Enteric fever. Next,
Yes, sir.
followed by
Mm,
what next? You said something in the history. You said some leg pains were not there.
it's a leptospirosis or
Leptospirosis,
yes, sir.
monsoon, yeah,
Or
leptospira.
malaria, malaria or dengue.
Malarial
Yes, sir.
hepatitis,
Mm,
falciparum can cause
yes,
hepatitis.
sir. Dengue
Okay,
also.
brucellosis can cause, melioidosis can cause.
Yes.
Okay, right, all these they are all very, very uncommon. And children will be much sicker than this. Syphilis not in a 9-year-old child, in infant agreed, it can cause cholestatic. Congenital syphilis can cause cholestatic hepatitis, not 9-year-old child with congenital syphilis. Okay, you don't expect acquired syphilis in a 9-year-old child, right?
Yes.
Okay. Okay, go to the physical findings. Dr. Vijay, you want to ask something else? Dr. Naresh, if you are there, you can ask some questions. Dr. Vijay, please, you can ask more questions if you want. Otherwise, we will proceed to physical examination. Please go to physical examination. Yeah. Please go ahead.
Yes.
Go ahead, Niranjan.
Yes, sir. On general physical examination, child was conscious, oriented, lying on the bed in supine position, appears sick looking and has lean build. Uh, he was febrile on touch with temperature being 98.2 degree Fahrenheit. His pulse rate was 92 per minute in right radial, measured in right radial artery. It was regular in rhythm, normal in volume, normal in character, with no radial or radiofemoral delay, and all peripheral pulses were palpable bilaterally. Respiratory rate was 20 per minute, and it was abdominothoracic type of breathing. Blood pressure was 106 by 72 millimeter mercury, which falls between 58 to 90th of centile. His oxygen saturation was 98% on room air.
Go ahead.
So, in
Was he trick or not?
yes, sir, he was ecteric.
Sorry,
He was
look,
ecteric.
I could have mentioned. Is he deeply ecteric or mildly ecteric?
He is deeply ecteric. Sir,
Right. If I were you, I would have, my opening statement would have been, he is thin built and he is deeply ecteric. Okay,
yes,
go ahead. Go ahead.
yes,
Please go ahead.
yes, sir. Sir, he had icterus was present as it was evident from yellowish discoloration of sclera and skin. Child was pale as and it was evident from his palms, tongue, and oral mucosa. There was no clubbing, cyanosis, lymphadenopathy, or edema.
Go ahead.
In head-to-toe examination, child had hemolytic faces, evident in the form of frontal bossing, prominent cheek, slightly depressed nasal bridge, and malocclusion of teeth.
Show me his face. Show me his face once more.
Yeah, yes, sir. Yes, sure, sir.
I'm not sure. Okay. Dr. Vijay, I don't know. I wouldn't say he has got hemolytic faces from your photograph.
I also don't think so.
I don't think so. I don't think he looks like a thin boy. I don't think he has got any hemolytic. You are biased.
So on
Actually,
examination,
Niranjan is getting deviated again and again towards the hemolysis
Yeah,
and hemolytic anemia, which is not okay, I think.
absolutely. He doesn't have any maxillary
Because this
prominence.
is a short history and we should focus on the short problem.
Correct.
yes.
The
I'm
long
not
part
agreeing
is
with
only
you.
of the unconjugated hyperbilirubinemia that happened in the neonatal period.
Correct. Go ahead.
Yes. Uh, Child was ecteric as evident. He had yellow discoloration of skin and sclera. Tongue, oral mucosa, and palms appeared pale. Hair, oral cavity, eyes, ears, nose, lips, and neck were normal. Chest is normal. Abdomen is distended with fullness seen in flanks. Umbilicus is stretched. Extremities are normal with no joint swelling. There is no evidence of bleeding manifestations or hyperpigmentation or scratch marks seen. Skin turgor is mildly reduced, suggesting mild dehydration.
Umbilicus is stretched means stretched down, stretched to the left, stretched to the right,
It is central in
transversely stretched.
transversely stretched. It is central in position, sir. It is not divided to. It is not divided from middle. It is in central position and it is stretched. It is a bit stretched.
push down.
Yes, sir. Good.
Okay, fine. You have a picture of the abdomen?
Yes, sir.
Okay, we'll see that. We'll see that. No problem. Go ahead.
On per abdomen examination, on inspection, there was mild generalized distinction of abdomen. There was fullness in flanks. Umbilicus is central in position and stretched. There is no visible peristalsis. There is no herniation, no scars, sinuses, or fistula, and there are no visible veins. On palpation, in superficial palpation, child has no local rise of temperature. There is no evident guarding or rigidity. Shifting dullness is present. There is no fluid thrill. On deep palpation, tenderness is present on predominantly over right hypochondriac region. Liver was palpable 4 centimeter below right costal margin in the mid clavicular line. Lower water was smooth. It had rounded margins. Surface was smooth. It was soft to firm in consistency, and it was tender on palpation. There is no nodularity, and liver span was around 13 centimeter. Spleen was just palpable. Percussion, liver dullness is present. Liver span measured 13 centimeter in the right mid clavicular line. Shifting dullness is present. Tympanic note heard over the remaining abdomen.
Go ahead.
On auscultation, bowel sounds were normally heard. There is no renal bruit or venous hum heard.
1 minute, 1 minute. You have a AP view of the abdomen picture?
No,
No,
sir.
you are
Actually,
showing from the side.
I have only lateral view, sir.
Lateral view. Okay, okay. Right, okay. Unfortunately, I don't know, but from what you are showing, it looks like the umbilicus is pushed down. If
Yes.
at all I can imagine, because your picture is not showing it completely. Umbilicus looks like it is shifted down, and as you rightly said, flanks are full,
Yes.
and you have shifting dullness, which indicates ascites.
Ascites, yes.
Ascites. But you didn't mention anything about the left lobe of the liver. Why is that important? Why you never mentioned anything about you? Please go back to, you have only mentioned that liver. Go back to the palpation. Yeah, you have mentioned palpable 4 centimeter below right midclavicular line. What about the left lobe of liver in the epigastric region or below the xiphoid? Is it important? And why is the left lobe important? Anybody can put in the chat box. Why should you talk about left lobe of liver whenever there is hepatomegaly? Specifically, anybody can put in the chat box? Okay, let me give you the clue. In any chronic liver disease, left lobe involvement indicates that the disease is chronic. It doesn't happen in an acute disease. So remember
Yes.
to palpate the liver in the below the xiphoid and mention,
Yes.
particularly if you get a firm liver in the epigastric region below the xiphoid, the left lobe being palpable, it indicates that the liver disease, whatever that is there, is chronic and not acute. So you should have mentioned about the left lobe of
Left
liver.
lobe of the liver.
And always when you talk about palpability of liver, you should talk about palpability below the midclavicular line, anterior line, as well as below the xiphoid. Don't forget that. Okay?
Yes. Yes.
Yeah. And what is the surface of the liver?
So the surface is smooth from what it from on palpation.
And you have put soft to firm in consistency.
Yes.
Why? Why? You are not sure whether it is firm or soft? What do you mean by soft to firm? It only
So
tells me sure. Am I right?
it was firm in consistency, sir, actually.
If I were you, when I have a doubt whether it is soft or firm, in such a child who has got deep jaundice, I would have straight away said it is firm and
Firm in
consistent.
consistency. Yes, sir.
More so if the edge is sharp. The edge is sharp, it is likely to be a firm liver. If the edge is rounded, it is likely to be a soft liver. You know, except in fatty liver, you do not get a soft hepatomegaly maybe in acute infection like leptospirosis, typhoid, you may get acute viral hepatitis, you may get a soft liver. But by and large, most hepatitis will get only a firm liver not with a rounded margin, with a sharp margin. Okay, go
Yes.
ahead. Spleen was just palpable. What do you mean by just palpable? What's the meaning of just palpable spleen? Does it mean 10 centimeter? Does it mean 5 centimeter? Please do not use such terms as just palpable.
Yes.
The spleen is palpable 1 centimeter, 2 centimeter. Remember, for practical purposes, splenomegaly is classified as mild, moderate, and severe.
Okay.
3 centimeter, 8 centimeter, more than 8 centimeter. So if it is less than 3 centimeter, you say mild splenomegaly of 1
Yes.
centimeter. Don't say just palpable.
Yes.
As rightly put by Vijay, you can't ignore that because spleen has to enlarge twice the normal size to make you palpate the tip of the spleen.
Yes.
Okay,
Yes.
right. Go ahead. What about genitals?
Genitals.
Genitals, you didn't mention anything about genitals.
Genitals were normal, sir, actually.
Yeah, you should mention. What is the importance of genital examination in a child with liver disease? Why should you examine the genitals?
So to look for signs of liver failure.
Like ascites, you can get edema
Ascites.
around the
Yes, sir.
penis, you can get hydrocele,
Yes.
you get vulvar edema, number one. Number two, any other clue? If you have a child who has got jaundice, who has got anemia, who has got hepatosplenomegaly, male child, palpate the scrotum for any testicular involvement of
Yes.
leukemia. Conditions like leukemia, lymphoma, any testicular involvement you can make out.
Yes.
Right?
Yes, sir.
And more importantly, in any child with an acute febrile illness with icterus, you should always look for eschar because eschars in pediatrics, unlike adults, they are not present in the exposed parts of the body. They are present in axilla, groin, behind the ear, like that. So look for eschar,
Yes.
right?
Yes,
That's
sir.
very important. Go ahead.
So in CNS examination, on general observation, child was conscious, alert, and cooperative during examination. He was well oriented to time, place, and person. Higher mental functions appeared normal. Child had slurred speech. There was no irritability or abnormal behavior or confusion or excessive somnolence. Glasgow Coma scale was normal. It was 15 of 15. In higher mental functions, child was conscious. Consciousness was intact as he was conscious and alert. He was oriented to time, place, and person. His attention and concentration was normal for age. His memory and comprehension was intact. But in speech, he had slurred speech, though comprehension was normal.
Go ahead.
On cranial nerve examination, pupils were bilaterally equal and reactive to light. Extraocular movements.
Normal. Cranial nerves are normal, isn't it?
Yes,
What
sir.
did you find? Anything abnormal you found in the CNS?
No, sir. It was. There was
Okay.
no. Yes.
Now I'm putting an open question to you. In a child with jaundice or liver disease, what are the important steps in the nervous system examination you will take?
So we could look for if there is a. So we could look for history of any abnormal movements like movement disorders like chorea, ectotoid, or
Well,
flapping tremors, or asterixis. Uh,
okay,
we can look for deep tendon reflexes whether they are exaggerated.
okay.
Okay, then
Anything else?
we can inquire about decline in scholastic performance if we are suspecting Wilson's disease
Very good.
with behavioral changes or altered.
Anything else? Anything? Most important clue will be loss of memory. Memory.
Yes.
Okay.
Yes.
Okay.
Yes,
Sleep
sir.
disturbance. Somebody has put in the chat box. Very important. Sleep
Altered sleep
disturbance,
pattern. No, sir.
behavior disturbance, memory, short and long-term memory, both will be affected. Particularly in a impending hepatic encephalopathy, short-term memory may be
Affected.
affected. There are
Yes.
scales actually, right?
Yes.
Assess occurrence of, assess the diagnosis of hepatic encephalopathy,
Yes.
right? Asterix is of course very important. Go ahead. And very important, so Dr. Vijay has put it, macrographia or micrographia, handwriting, literature
Yes.
could be a feature of extrapyramidal involvement like in Wilson's. Right, go ahead.
In cranial nerve examination, pupils were bilaterally equal and reacted to light. Extraocular movements were normal. There was no evident nystagmus of facial asymmetry. There was more distant hearing loss since at 4 years of age. Parietal movements were symmetrical. Tongue was central in position without fasciculations. In motor system, child had normal muscle bulk and muscle tone in all extremities. Power was normal in all muscle groups. There was no history of any involuntary movements like tremors, chorea, dystonia, abnormal posturing, or flapping tremors. Deep tendon reflexes were present symmetrically. They were all demonstrable. They were normal, sir. In superficial reflexes, abdominal reflexes were present. Plantar response was flexile bilaterally. In coordination test, finger, nose, heel, shin, rapid alternating movements were normal, and there were no cerebral signs seen. On sensory examination, higher sensory functions were intact, and primary sensations like pain, touch, temperature, vibrations, and joint positions were preserved. And there was no evidence of any sensory deficit. In gait was normal. There was no ataxia. And in meningeal signs, there was no evident neck stiffness or any Kearney's or Brzezinski signs were negative. So.
Okay, what about hearing? Rajnish test and Weber's test. Did you do?
No.
No, you should do. You are saying that there is some hearing disturbance. You have to find out whether a conductive hearing loss or sensory
Yes.
by doing Weber's and Rajnish.
Yes.
You have to find out whether it is unilateral or bilateral hearing loss. Okay?
Yes,
And
sir.
ocular movements you have to describe fully.
Yes.
And frame, whether you look for or if it is present, you have to mention. You have to also look at the fundus,
Yes.
right?
Yes, sir.
Very important to do all those maneuvers in the
Yes.
nervous system, right? But you
Yes.
mentioned child is having hearing loss. If you don't do Bieber's and Rennie's in a 9-year-old child, the examiner can find fault with you.
Yes.
Okay?
Yes.
Right. Go ahead. Right. Go ahead. Other systems are normal, isn't
So
it?
other systems were normal. Like respiratory system and cardiovascular system were normal. There were no any significant findings noted so far.
Okay. Okay. Good.
Yes.
What about his gait? Gait is normal?
Gait is normal, sir.
Okay. Now with this, what is your clinical diagnosis at this point of time? Okay, don't go to investigations. I don't want to see investigation. Dr. Vijay, you want to question him more? You can ask before we ask him what is the diagnosis. Dr. Vijay, please.
I just want to again ask what you are asking, that what is the probable diagnosis in this patient?
Good. What is your probable diagnosis? Yes.
So I think it is infectious.
Sum up the case and give a probable diagnosis.
Yes. So,
No, we don't want to say hemoglobin.
no, sir. I'm going to summarize.
I don't want any tests.
9 years old male child, Riyan Sethia, who is developmentally normal with moderate hearing loss and slurring of speech, noticed at 4 years of age.
Again, it will be better if you don't read. If you
Okay,
don't read and just summarize.
First, you can't say developmentally normal in a
Yes.
child who has moderate hearing.
Moderate hearing loss.
Speech.
Yes.
But it should be the other way, who's developmentally abnormal
Yes.
with moderate hearing loss. Okay, I
Yeah.
don't think your statement saying that he is developmentally normal is appropriate.
Yes.
Yeah, please correct yourself from the exam point of view.
Yes,
Doctor,
sir.
okay, go ahead.
So I am thinking of it. It is more towards infectious hepatitis, like viral, sir, mostly.
Hmm.
From what it seems from the history. And
Hmm.
child has bowel and bladder habits were normal. So I'm not suspecting enteric fever either. So it is more of a infectious hepatitis like viral etiology.
This infectious hepatitis, which is acute or chronic?
Acute, sir.
Acute. Okay. Is there hepatocellular failure in this child or not? Is there
Since,
hepatocellular failure in this child or not?
sir, as
Is
child
there
has,
hepatocellular failure? Can anybody put in the chat box yes or no? Is there hepatocellular failure or not? I'm asking an exam question for this case. What is anybody, any other student? Ashita is putting no. Vijay himself is putting no. Anybody else? Okay. I will ask you a simple question. This child is deeply icteric and has got ascites. What is the cause for ascites, Dr. Niranjan?
um,
What is the cause for ascites in this child?
so it could be due to hepatitis.
Hepatitis, how does hepatitis cause ascites? When does hepatitis cause ascites, and how does it cause ascites? See, the presence of deep jaundice with ascites indicates that there is acute hepatocellular failure.
Failure. Yes.
Here, see, after all, ascites can develop in a child with a hepatocellular disorder either because of portal hypertension or because of hypoalbuminemia,
Mm.
right?
Yes.
Right? With
They
spleen
could.
being just palpable, no prominent veins, no hematemesis, no melena. Here, the presence of ascites in a child who is deeply intrigued should be taken as unequivocal evidence for hepatocellular failure. If I were you, I would say because of the presence of ascites, this child is probably having acute hepatocellular failure. Duration is short. So I would have said acute hepatocellular failure
Yes.
with acute hepatitis. That would be my diagnosis.
Yes.
I agree that it could be a hepatitis A or E or B is very, very unlikely today.
Yes.
Universal vaccination. I don't
Vaccination.
think
Yes.
child will present with at 9 years due to with hepatitis B, and such that too in an acute manner. Right? Uh,
Yes.
so I don't think I will think of that. Think of that. Now, in addition, your diagnosis should also include the following. First, you should say it is acute hepatitis with
Yes.
acute hepatocellular failure, most probably a viral hepatitis.
Yes,
That
sir.
would be. In addition, this child has also got an underlying hearing deficit with speech disturbance
Yes.
secondary to neonatal unconjugated
Hyperbilirubinemia.
hyperbilirubinemia, for
Yes.
which the cause is not obvious. Unless, of course, you could have asked about the blood group of the baby and the mother. Did you ask?
Yes, sir. I had mentioned it in birth history, sir.
Yeah. It's not likely to be ABO incompatibility or
No,
RBO
no, it was
incompatibility.
not ABN compatibility, sir.
Unconjugated, we don't know the cause. We don't know
Yes.
the cause. That probably has resulted in the hearing deficit. And I
Yes.
think that unconjugated hyperbilirubinemia and the present conjugated hyperbilirubinemia are probably unrelated. Right?
Yes.
I wouldn't, of course, I don't know, you didn't mention about pallor in this child. I didn't see severe anemia, at least from the pictures I wouldn't have thought of hemolytic anemia. for several reasons. One is that child is not looking all that pale, and I don't agree with you on the diagnosis of a facial dysmorphism secondary to you. I don't think this child has got a hemolytic faces. And again, if it is chronic hemolytic anemia causing so much of disturbance, spleen won't be just palpable, it will be much more than what it is. You will at least get a moderate splenomegaly if it is a chronic hemolytic anemia. Okay. And
Yes, sir.
PD deficiency, I don't know. I don't know how I wouldn't make a diagnosis at all when there is so much of icterus with yellow urine. Is usually a unconjugated hyperbilirubinemia,
Yes.
right? And you don't get fever. You don't get fever, right? In G6PD 9 years, first time jaundice, so much of deep icterus without much of pallor, extremely unlikely unless you make two diagnoses, right?
Yes.
So
Yes,
what
sir.
do you do? Dr. Vijay, you want to ask more questions before we go and find out what investigations are required, etc. Dr. Vijay, please. Sir.
Will you please tell that what is the management of viral hepatitis?
Yes, anybody can
Yes,
put
sir.
in the chat box. Acute viral hepatitis.
Good.
Oh, you already put the final diagnosis, huh? IgM, hepatitis A, B, hepatitis A positive, hemolytic anemia, G6PD deficiency, speech impairment. Okay, you know everything. I'm not biased, but I don't know much. Right, go ahead. So answer Sir's question
So
first.
we could manage symptomatically, like we could do pain management. We could give hydration. Since there was history of anorexia, so uh, child has to be started on IV fluids.
Hmm. Hmm. What else you do?
So we could give supplements like multivitamins.
They won't do anything for anybody,
Yeah.
including this child.
What happened to the ascites in this child?
Okay, before that,
Yes, sir.
how do you investigate this child? Please tell me how you investigate this child.
So we will do complete blood count.
Yeah, what are the complete? Now give us the complete blood counts.
Yes.
Yeah, you show us the data now. Complete blood count. What does it show? Yeah,
So on
hemoglobin.
admission,
Yeah, go ahead.
so on admission, child hemoglobin was 7.1. So he had anemia. Yes, MCB was 87.1. MCH was 28.6. MCHC was 32.9. So
What about the peripheral smear?
yes, I am on. So peripheral smear, sir, it was findings for suggestive hemolytic anemia as it is evident from RBC morphology. There were presence of anisopoikilocytosis, macrocytes, teardrop cells were seen, fragmented cells were seen, and hypochromia was seen. In WBC morphology, there was no immature leukocytes seen, and nucleated RBC was 4 of 100. Platelet count was adequate, sir. So it was overall, it was a picture of hemolytic anemia from what it seems.
Were there any burst cells seen in the peripheral smear?
No, sir.
They can be seen even in hepatocellular failure,
Yes.
not necessarily in hemolytic uremic syndrome alone, right?
Yes.
Okay, peripheral smear showing hemolysis. Okay, what else will you do? What other investigation did you do?
So we'll do a liver function test, renal function test.
Yeah, liver function test. Show us the liver function test. And
Yes, sir. So serial
renal
investigations were
function
done
test
for
report.
4 days. Yes.
Okay, is bilirubin is 42? Is it on admission?
Yes, sir. On 4th of July.
42, direct 26, indirect 15.9, SGPT in thousands, PT more than OT, alkaline phosphatase is okay. What about gamma GT? No, not raised.
No.
Okay, total protein, albumin is lowered, not very low, 3.1.
Yes.
Right. 40, 28. Okay. Now, what about prothrombin time?
Yes.
Prothrombin time. Yeah, it was elevated,
Yes.
indicating, okay, reverse heart failure. What
Yes.
about
sir.
renal function test?
Yes. Renal function. So renal function test was normal. So it is
Normal, urea
yes.
creatinine. Okay. Right, right. What about hepatitis A, IgM?
IgM was reactive, so I'll show.
Reactive. What is the significance of IgM positivity in hepatitis A? How long can it remain positive? Anybody can put in the chat box. How long can hepatitis A IgM remain positive after hepatitis A infection occurs? The answer is up to 6 months to
6
1 year.
months.
6 months to 1 year, not 3 to 6 months. It is 6 months to 1 year. It can remain positive. So it can be misleading. Sometimes there are reports where people miss out Wilson's thinking it is hepatitis A because hepatitis A IgM can coexist with Wilson's disease or with some other chronic liver disease, right? So
Yes.
you should not simply go by only hepatitis A IgM. You should make sure you don't miss other diagnoses.
Yes.
Okay, because as you rightly mentioned, you had done a HbA1c, but of course, in the presence of severe anemia, yes, male child doing G6PD is fair enough. Reticulocyte count indicate there is hemolysis.
Hemolysis. Yes.
Direct Coombs test is positive. What does that indicate?
So it could be. It can be autoimmune. It points towards autoimmune hemolytic anemia. So,
Not necessarily. It could be part of an infection causing autoimmune hemolysis also, right?
yes. Yes.
Mycoplasma, pneumococcal infection, even viral
Yes.
infection can induce Coombs test positive hemolytic anemia. Agreed. Malaria test is negative. Ceruloplasmin, IgM, okay, blood group is fine. The other test I might have considered in this child, would include okay, retic count, viral markers, hepatitis B. Fair enough.
Yes.
Okay. The fever had been high on presentation. I might have taken a blood culture also. Sometimes, there can be comorbid enteric fever, comorbid leptospirosis, okay,
Yes.
comorbid treatable bacterial infections. So, blood culture might have been in order if the fever had been high, right?
Yes.
Good.
Yes.
Sir, G6PD is they have done and it is deficient, right? I
Yes.
don't know how they put unit per gram, how they give the G6PD reports, right? It's low, agreed. Male child low, agreed. Right. Next. Yeah, go ahead.
The USG ultrasound abdomen was done,
Yeah.
and findings were there was hepatomegaly with acute parenchymal changes suggestive of hepatitis, mild ascites in the form of pelvic free fluid, and there was splenomegaly.
Okay. Okay.
Spleen
That's
size
all
was
there. Nothing more than what you found out clinically. Next slide. What's the usefulness of ultrasound in a child who has got an acute jaundice like this, other than the findings that you have seen? How does it help you? You can make a diagnosis of calculus cholecystitis
yes,
or cholangitis. As somebody has put in the chat box, chronic liver disease like cirrhosis, you can make out with ultrasound, right?
yes,
Okay, you can make out a liver abscess, which can also present like this, but not usual to present with severe jaundice. Okay,
yes.
what else? Yeah, how did you treat this child? What did you do for this child?
For firstly, I give symptomatic management as child had pain in abdomen, so antispasmodics was given. Child had fever, so
Antispasmodics have no role in the
yes,
treatment of any abdominal pain. They have
yes,
no role. Don't mention antispasmodics. They only
yes,
produce constipation.
yes.
So dicyclamine, all those antispasmodics, please don't use them. They have no
Uh,
role,
yes,
right?
Sir,
Then,
I'll observe the child whether the hepatitis progresses to acute liver failure. Then,
see, you should have given vitamin K first.
yes,
That should be the first step.
yes.
Vitamin K, because the prothrombin time is elevated. You should,
Elevated to 1 point, yes,
yeah,
ionism.
yeah, you
Yes.
should give for 3 days and
Mm.
repeat the prothrombin time.
Yes.
You give a high carbohydrate, low fat, low protein diet. You should ensure that there is no constipation, and you should give lactulose. Why do you give lactulose in acute severe hepatitis?
So to prevent hyperammonemia, as
How does it prevent? How does lactulose help prevent hyperammonemia?
sir, it converts ammonia to ammonium ion and it is excreted through the gut.
Okay, it's a what type of drug is lactulose? What is it?
Lactulose is
Can anybody put in the chat box?
laxative.
Is it a carbohydrate? Is it a protein or a lipid? Anybody? It is a disaccharide.
Diacetyl.
Lactulose is an unabsorbable disaccharide.
Yes.
It is not absorbed, so it is converted into hydrogen ions. So it produces an acid pH in the bowel, which removes all the nitrites and gets excreted.
Yes.
It's an osmotic laxative. Okay.
Yes, sir.
So it helps reduce the ammonia levels.
Ammonia. Yes.
Ammonia levels. Preventive method. Then what else will you do? No antivirals have been proven to have any
Yes, sir.
role in the treatment of hepatitis
Hepatitis. Yes.
A. G6PD, you have to counsel the parents.
Yes, sir.
What do you counsel them?
Sir, parents should be counseled to that they should avoid any triggering factors like drugs like sulfonamides or or chloroquines or
Very
antibiotics like primaquine, tafenoquine
excellent.
or naphthalene balls or raspberry
Excellent.
case.
Yeah, you should counsel regarding drugs
Any
which
in
precipitate hemolysis in
G6PD.
G6PD
Yes.
deficiency, right? Okay, right.
Yes. Then they should be made aware that infectious they might be some infectious triggers which could which could lead to hemolysis. Then they should avoid fava beans
Okay, flower
and
beans in India,
yes,
very rare.
yes, sir. And
Okay.
genetic counseling should be done, sir. And
Okay. What is the mode of inheritance? What's the mode of
it is
inheritance?
X-linked recessive disorder. So
Yeah, it's rare in females, mostly
yes,
seen in boys. Okay,
yes.
that's what you should counsel. And one more question is, if this is hepatitis A, could you have prevented this?
So preventive measures could have been safer sanitary practices, maintaining hygiene, avoid eating contaminated foods or eating from outside.
Mm.
So then,
Equal
we
or
could vaccinate the
equal or
child. Yes.
vaccination? Yeah, vaccination. What are
Yes.
the types of vaccines available for hepatitis A?
So there are two types of vaccine like inactivated and killed inactivated and live attenuated vaccines.
Okay. What age hepatitis A vaccine is given?
So it is given at the age of 12 months and second dose is
Why 12 months? Why not give earlier? Why not give earlier? Why give at 12 months? Very simple. Maternal antibodies will prevent development of good immunity following vaccine. Most mothers will have hepatitis A, IgG. That will
Yes.
protect. It transmitted the first year, you won't get good response. That's one of the reasons why hepatitis A and chicken pox is not given below 1 year.
1 year. Yes.
Okay. Live vaccine is one dose, single dose given at 1 year. If
Yes.
it is inactivated vaccine, 0 and 6 months. That is at 12 months, first dose, and 18 months, second
18
dose.
months, second dose. Yes.
Second dose. And both the vaccines have been found to be equally effective. There's good data, but that these vaccines are effective for more than nearly 17, 20 years, both in India and in several parts of the world. And
Yes.
suppose there is a sibling at home. This is only child, isn't it? This is only first child, isn't it?
No, he's third by birth order. He has two elder
Third.
sisters. So.
Yeah, two. So how do you prevent the disease from getting transmitted to other children right now? They are not vaccinated. So what do you do? What do you do? Anybody can put in the chat box?
So
Okay.
maintain hygiene and
No, nothing. Of course, you cannot isolate for 1 month.
yes, sir,
Now,
no.
two things. It's a fecal-oral route transmission. So there are two ways in which you can prevent hepatitis A following post-exposure. One is give the vaccine. The vaccine antibodies will start rising after 2 weeks. But the incubation period of hepatitis A is 2 to 4 weeks. It may
Yes.
prevent, it may not prevent. But the most foolproof method is giving
Vaccine.
human normal immunoglobulin,
Okay.
intramuscular, single dose. I don't know the dose. I think it's about 1.5 ml. Please go and check up. Human normal immunoglobulin available as bar globe. You can give a single dose intramuscularly to those exposed to hepatitis A for passive prophylaxis. It can also prevent measles. Measles and hepatitis A are two indications for preventing these diseases by administration of intramuscular human normal immunoglobulin.
Yes.
Okay, right.
Yes.
Over to Dr. Vijay and Dr. Naresh. And any questions from the postgraduates, I'm more than willing to answer. Very good presentation, Dr. Niranjan.
Thank you, sir.
Extremely well. You did extremely well. I must compliment you. It's a difficult.
Thank you, sir.
Of course, your history nor the physical findings suggested any hemolytic anemia to me. And one more thing, in G6PD deficiency, very, very unusual to have hemolytic phases. I've seen quite a few cases of G6PD deficiency. I've never seen anyone have thalassaemic phases or hemolytic phases. So that's the point I wanted to raise. Because Dr. Others in your Bhilai would have much more experience. Dr. Vijay, you can add to the discussion. Thank you.
Will you please tell that can we have a relapsing type of hepatitis in some patients?
Yes, sir.
Can viral hepatitis A have a relapsing presentation?
Relapsing? I've not seen. At least books don't mention that because they say one attack of hepatitis A gives lifelong protection. The IgG antibodies give, coming to the, okay, Dr. Niranjan,
Yes,
few
sir.
more questions. What are the complications of hepatitis A?
It can acute liver failure, hepatic encephalopathy.
Okay, 1% death. That should be your
Yes.
answer due to acute hepatitis
1%.
failure. 1% of those with acute hepatitis A may die of fulminant hepatocellular failure. There is no chronicity. There is no carrier state. That's the second and third point you should mention in the answer.
Yes, sir.
Okay, 99% recover. Another important point you must remember with regard to hepatitis A, most hepatitis A in young children are anictric. In older children, they are ectric. That's another important point. Child coming with fever, vomiting, anorexia for 2 days may well be anictric hepatitis A. Unless you test, you won't be able to diagnose. Ectric hepatitis A is less common than anictric hepatitis A, particularly in infants and children. Older children, adolescents, adults, ectric hepatitis A is more common than hepatitis B when in hepatitis A. And hepatitis B got a long incubation period. Hepatitis A has got a short incubation period. Extrahepatic manifestations are unusual in hepatitis A. The uncommon complications other than acute hepatocellular failure in hepatitis A are as follows. One, it can cause aplastic anemia. It can cause pancreatitis. It can cause myocarditis. It can cause Guillain-Barré. It can cause ADEM. Right? All these complications are unusual, but they can all occur. Aplastic anemia can be fatal following the occurrence of acute hepatitis A. Glomerulonephritis also is reported. right? Neurological complications, many have been reported even after vaccines. Okay, that is regarding. There is no chronic state in hepatitis A. And even those who have Wilson's, those who have chronic liver cell disease, they can die of hepatitis A as an incidental infection. Okay, that's
Yes.
all. Over to Vijay and Naresh. Thank you. And Sandeep.
Thank you, sir. Thank you. Vijay sir,
Will
do
you
you have any
please
more
tell-
questions?
Will you please tell which
You can
vaccine is
stop sharing
preferred
the
for the
slide, Dr.
post-exposure
Sandeep.
prophylaxis?
Sandeep, you can stop sharing
Yeah.
the slides.
Niranjan, please stop sharing the slide.
Please stop.
Yes.
Yeah. Thank you.
Which vaccine is preferably used for post-exposure prophylaxis?
Sir, inactivated vaccine is preferred, sir. Like,
Why? You are correct, but why?
yes, sir. Not sure.
It uses the antibodies much faster than the live attenuated one.
Yes.
Therefore, it is preferred.
Yes.
How long the virus is shed and when the virus is shed by the asymptomatic child. As Dr. Balasubramanian told that under 6 years it is usually unectric when the virus is mostly shed.
Around
It is done in the
five.
late incubation period.
Yes.
Incubation period. And it may
Yes.
go on for 1 to 2 months. So we have to be very much cautious.
Yes.
It may present as gastroenteritis initially or vague features. I think we'll stop here.
Yeah.
Thank you, sir.
If
Well
Dr.
done,
Bala
Niranjan.
wants to add
Thank
anything.
you, sir.
Yeah, nothing except that compliments to Niranjan. You did
Thanks.
extremely well, though
Thank
we
you,
had
sir.
difficult questions to complete the discussion and make it lively and interesting. Thank you very much.
Thank you, sir.
Thank you, sir. There are no more questions in the chat box. So, thank you everyone for joining today's session of PG Clinics. Our sincere gratitude to our distinguished experts, Dr. Balasubramanian sir and Dr. Vijay Makhija sir, for sharing their invaluable insights and their guidance. A big congratulations to Dr. Niranjan for an excellent presentation. We
Thank
also
you, sir.
extend our deep appreciation to all CGAP and DBAP office bearers, faculties, all the attendees, all postgraduates, and Team Juventus for their active participation and support. Thank you all for joining. Thank you and good night all. Thank you.
Thank you, sir.